I would like to welcome our next speaker, Dr. Ljubo Znaor from Croatia. He will speak about pneumatic retinopexy reevaluated.
Thank you very much. Thank you for inviting me here today. I will talk, let's start with the presentation. Okay, so I would like to talk about another technique for resolving retinal detachments. So as we know, pneumatic retinopexy is mostly popular in United States and Canada, while in European countries it's mostly neglected technique. So we see that it's mostly used in United Kingdom, and in German-speaking countries, only 5% of vitreoretinal surgeons use this technique. For what regards our experience with pneumatic retinopexy, you can notice that since 2012 until 2014, the number of pneumatic retinopexies at our department increased steadily. And now, since 2014 till now, the number is practically steady. So I would like to share with you the results of 97 patients that we treated in the last 3 years with pneumatic retinopexy. Their mean age was about 60 years. We consider as eligible for pneumatic retinopexy people who have retinal detachments with a single or multiple contiguous breaks, which are positioned between 9 and 3 o'clock. And the very important prerequisite is that they have a clear optical medium and that warrants the good fundoscopic exam. We do not treat people with lattice degeneration which are too far away from original retinal breaks, which cause the retinal detachments. We do not treat also, obviously, the people with the PVR grade C or D, or if we judge that the patient is not going to be able to maintain postoperative head position. So here are some data about the people who were treated. We had more male and female patients. What is very important here is that 79% were phakic, while only 21% were pseudophakic or aphakic. Then we have some data about how many quadrants were detached. Only 11% of patients had some vitreous hemorrhages. 43% had macula off detachment, and 8% had multiple contiguous retinal breaks. So for what regards the technique, we use local anesthesia, retrobulbar injection of lidocaine. Then we proceed with the light cryo under the indirect ophthalmoscopy. Then we prepare and treat the surface of the eye with 10% betadine, and we perform the translimbal paracentesis with the plungerless syringe equipped with the 30-gauge needle in order to lower the IOP. Then we inject the pure half milliliter of SF6, and we check immediately the perfusion of the central retinal artery. After the application of the local antibiotics, we instruct the patient how he should maintain the position. And we tell them to intend to maintain that position for at least 6 hours in continuation after the surgery, and then as much as they can. Here we have one case of bullous retinal detachment with 2 contiguous retinal breaks, which are here. The visual acuity was really poor because of the macula off retinal detachment, And on the right side, we see the situation 6 months post-operatively, where the visual acuity was only 0.3. The retina was completely attached, but the poor visual acuity is probably caused by the foveal atrophy. The mean follow-up time was of 14.2 months, minimum 6 months. And we see on this graph that both macula on and off, especially macula off retinal detachments, had an increase of visual acuity after surgery. For what regards the complications, we had 12% of patients which had a rise in intraocular pressure, which was dealt only by local treatment. 6 eyes had new or preoperatively missed breaks. 3 eyes developed PVR, and 6 eyes delayed subretinal fluid absorption. So the single operation success rate in these 97 patients was of 80.4%, and final success of 98%, which is, as we see, in the range of previously reported success rates of pneumatic retinopexy. So 19 eyes did not, they failed in reattaching the retina after pneumatic retinopexy, and when we controlled various factors that can influence the rate of retinal reattachment, we found that the number of retinal breaks, the existence of partial hemophthalmos, and the number of quadrants which were detached did not influence at all the success rates of pneumatic retinopexy. Although when we controlled the cataract or the lens status, there was a statistically very significant difference in success rates between the group of patients who had their cataract operated previously to retinal detachment in comparison to the patients who did not, who had their natural lens in place. So that means that people who have who are pseudophakic have 1.43 times higher the chance of failure of pneumatic retinopexy. So here we have one case where the primary operation has failed, and as you can notice from the right side picture of the anterior segment, that this was a traumatized eye. And this patient was had his cataract operated, and after a few years he developed the superior retinal detachment, and 6 months post-operatively after the pneumatic retinopexy, he developed the inferior retinal detachment. And during the vitrectomy, obviously there was a lattice degeneration which was overseen before pneumatic retinopexy because of the state of the pure dilation of the pupil. And for what regards the retinal tear positions, we here in this diagram we see the success rates for every quadrant that we treated. And we saw that there was no statistical difference among those positions. But we can notice that there are 2 positions of the retinal tears which had lower success rates, and that is on 10 and 2 o'clock positions. When we compare and combine the success rates of the retinal breaks which were positioned at 10 and 2 o'clock and compare them to the rest of clock hours that we treated, there was a statistically important difference. So that means that patients who have the retinal tears at 10 and 2 o'clock positions have 1.72 times higher risk of failure after the pneumatic retinopexy. So we can conclude that the pneumatic retinopexy is still a valid alternative to other retinal detachment surgery techniques. We can see from this diagram that the greatest success rates we can expect from retinal tears which are positioned in a green area, somewhat lower but still very useful. Success rates are at 3 and 9 o'clock positions, evidenced in yellow, but we have to be cautious with the retinal tears which are positioned in positions 10 and 2 o'clock. And also we have to bear in mind if the patient is pseudophakic and aphakic. If the retinal detachment does not resolve after pneumatic retinopexy, and from my clinical experience, I would say in 48 hours, if you don't see the retinal detachment resolving, then you should not delay the rescue operation. And in that way, you actually are maintaining and not jeopardizing the success rate of the next operation. And for what regards the cost effectiveness, I think that this is the most cost effective treatment for retinal detachment. Thank you very much.
Thank you. Thank you so much. Excellent presentation. We have a question.
Very excellent results, and I use as well this technique.
So you are one of those German-speaking surgeons who is among 5%.
So please tell me regarding the methods. You wrote you use antibiotics. What do you mean?
No, it's just topical antibiotics.
But you use the syringe, the needle, to puncture the anterior chamber.
Yes.
Do you make afterwards the infiltration of the orifice or no?
No, it's self-sealing.
It's not self-sealing.
It's
the problem. This is the very interesting problem, and we show that with the needles, the needle is round, and the needle is polished. The end is polished. That's why it is sharp. But it is sharp not from the outer side, but always from the inner side, inner edge. And puncturing with the needle, I do the same with the needle, but I'm cautious what I'm doing. Puncturing with the needle, the cornea, we cutting out the very thin slope cylinder of the tissue, and it is not self-sealing, and it can be a risk for contamination.
But I feel that since you, excuse me.
No, go ahead.
Since you inflate the eye, you rise the pressure. So the flow, if you have any flow, it's only outwards. So until it heals. So I feel that there is no backward flow. So while you are in a hypotenuse eye, you are in a sterile situation. And after the surgery, I feel that there is not so many risk of getting endophthalmitis because of the pressure which is rather high immediately after the surgery.
Thank you.
But anyhow, this is a good point. With the needle, we just open a door that cannot be completely closed, so we should bear it in mind.
Even is this small orifice of you use, I suppose, 30 gauge needle. Yes.
30,
yes.
Of course.
Even 30 gauge opening, you can you can hydrotize. You can
probably, but
you can put place your cannula with a syringe.
Water to close it. Yeah.
It could be a good advice.
I actually agree that this is one of the surgical techniques that we cannot put aside completely. Sometimes it saves the OR schedule.
Absolutely.
And it saves you time, and you have a retinal detachment, you have no time to make a whole scleral buckle or vitrectomy, and it allows a good reabsorption of fluid at least to reschedule the patient maybe 2 or 3 days after. So it's another way to look at it.
That was our...
Your approach.
We are the department which is serving the 500,000 population normally, and during the summer we have even more. So
scheduling problem.
It's the problem of scheduling.
But the issue is that
was pushing us
if
technique.
we look at it this way, we have to make sure that we are not compromising, jeopardizing. And the key point that you highlighted is that the eye has to have no other lattice degeneration that may induce more break inferiorly, and then actually
if you are not 100%
make it more complicated.
That you have revised completely the retina, maybe it's better to think of another technique.
I observed from your initial table that the increasing number of PR were comparable to decrease of sclera buckling more than vitrectomy.
Yes, because mostly we perform this kind of technique in now more and more on people who are phakic, and they are younger, with not old retinal detachments. So they were the
sclera buckling previously selection. Okay.
That is mostly the problem.
And you added as an exclusion criteria the, let's say, not clear media, the absence of clear media. I tried to perform this technique with the chandelier light. It's not so cost effective at that point, but you may open up new indications because you can see much better what you're doing.
That's a good idea.
Okay. Thank you.
Thank you very much.